Greetings, everybody. We start in about 35 minutes. Okay, we start in about 30 minutes, everybody. And welcome. A todas las personas. I don't know. Let me see what backgrounds I have here. And you guys can vote on them. Okay, which one should I use? Maybe we'll just go back to the tried and true. No. Hello, Prof. How you doing, Prof? Are you there? I'm gonna make you co-host there, Prof. Okay, and your partner in crime too. Let's see.
Okay, Dr. John. Hello,
Oh,
can you hear?
how you doing?
I'm fine. How have you been?
I can't. Your camera on or no?
Yeah, I'll just turn it on in a minute.
Yeah, because I don't know whether you should bow or salute. Which do you prefer?
None.
Neither? What do you mean? Okay, I'll forego that today. But you gotta get on camera.
Turned on, Dr. John.
I don't see you. Where are I? Okay, let me get the spotlight on. Because we want the public to see me, how I treat my associates. Let's see here. Where's your, I don't see your camera. I see Zico. There you are. Okay. I guess, yeah. Yeah, the bandwidth, you're gonna, it's tough on the video to have both. So if you have trouble, just turn your video, your photo off. You know that, right?
Yes, Dr. John.
Okay, a little salute, no, little one. You can't bow. You don't have room to bow. Okay, okay. No, basically, you know what to do. You can mute people, right? Oh, there's Pinky. Okay, is this Pinky in here? Okay. Now see if she listens to me when I ask her to salute, okay? We'll test. We'll test her. I bet she does. Pinky, you there? Hello, Pinky?
Hello, Hello, Dr. John. Hello, Prashna.
Well, I was asking Prof if she would rather salute me or bow to me. Which do you prefer? Which do you prefer?
I would salute you.
Neither one, right? Okay. Well, anyways.
How are you?
Oh, good. I'm great. I'm looking forward to this. So you're going to be one of the co-hosts, right? So you see the panel on the right. Oh, let me make you one right now, because you're going to have to mute people because sometimes they forget. You know what I mean? I'm sure you've been to webinars where you hear extraneous noise. Okay, and you guys are going to help me combat that. Okay, have you done this before, Pinky? You haven't done this
yes,
before,
doctor.
right? No, you haven't done this before, right?
I've been a co-host before, so
okay.
I have a bit of experience.
Oh, okay. So you know what you're doing.
Yeah.
Well, at least you can pretend you know what you're doing. Okay, very good. And that's basically it. We've never had to kick people out. I mean, very rare. But it's a muting is the main thing. So, anyways, so welcome.
Yeah.
Welcome. And okay, and I'll put the spotlight back on the nice screen we have here, even though it includes me. I don't know much about virtual reality, but I guess we're going to find out. I invited a gentleman that worked on Microsoft HoloLens. He has backgrounds in the augmented reality, virtual reality, and his name is Jason Evans. I hope he comes. He said he was. Should be starting in about 14 minutes. Let me send a note to Aida. Okay, Pinky and Prath.
Yes, doctor.
Well, you've heard those stories about, you know, people in planes, small planes, and the pilot's flying, and the pilot dies, and the people have to take over and learn. They have to land the plane, and they've done it successfully. Have you heard of that?
Um,
Have you ever heard that story?
No, doctor.
no, doctor.
Okay, okay. It may, if I die in the next couple of hours, now you guys are going to have to take over the pilot's seat. Okay. That's supposed to be a joke.
We wouldn't wish for you to die.
No, of course not. But if it happens, if you come back and I'm slumped over, you got to take over the microphone and say, "Okay, I got to take over now." Although
Try,
some people, you'll try. Okay, good. So in other words, you guys have the responsibility. No matter what happens, take over. Okay, I told, okay. It's always a creeping thought in your mind that what happens if they don't show? It's only happened once, I think. Some people just like to come in at the last minute. Okay, 10 minutes. I'd like to try to start on time. Sometimes we can, sometimes we can't. Pinky Prath.
Yes, doctor.
Yeah, I'll introduce you to Aida before we start, okay?
Sure, Dr. John.
Yeah, I'd like you to meet her because, I mean, that's the value of these meetings is interaction and meeting people. You might meet her after, but hopefully we have a few minutes here. You can briefly meet her. And anyone else that wants to briefly meet her before we start. And after, too, is a networking possibility to hang around after we end the formal webcast. I leave the room open and chat a little bit with some people, and that's a good time to meet people also, not necessarily the speaker, but anybody. So, yeah, I heard from Aida. She just said she's coming in. So don't worry, it's going to happen. Are you excited, Pinky and Pratha? Do you feel the tension? Do you feel the excitement in the air?
Yeah,
Do you feel it?
Yeah, the
yeah, I'm
topic.
excited for the topic since it's really interesting.
Well, yeah, it is. It's cold there in Nepal, right?
Yeah, very
Yeah.
cold.
Very cold now. She's also a medical student, so I guess are there any other medical students on the panel? I guess not. I've got to name a syndrome. Oh, here's Ada. Okay. Hey, Jason.
Hi, good morning, John.
Hey, Jason. This is how professional we are. Do you want to host? No, really. Hey, Ada, how you
Hi,
doing?
Dr. Bennett. How are you?
Nice to meet you.
Nice to meet you too. Really nice to meet you too. And yeah.
Well, this is how professional this production is. It's about to start, and I'm asking someone to be the co-host, to be the host, actually. But you know, I find in my experience, I need to, it'd be good to keep the conversation going if I had someone like Jason, because he knows the field that you're talking about, and I really don't. And I really don't know neurosurgery either. So anyways, I think he'll cover that. And then what I'll do, Jason, I'll just basically introduce Ada, and she'll do a presentation, and then I'll turn it over to you. Let's turn it over to Jason to moderate the questions or feedback, okay? Does that sound like a plan?
Sure, I'd be happy to do that.
Great. Thanks. How you been, Jason?
Oh, very well, thank you. How's everyone keeping during this pandemic?
Oh, they're hanging in there. They're just hanging.
Yeah.
Thank goodness there's a light at the end of the tunnel. So Ada, you're a busy girl, man. Hey, that was great the way you came in to the UHA's presentation. Man, you had a mission. Boom, you accomplished a mission and you left town.
Oh, thank you. I actually was on the wards. I wish I could have stayed for longer, but then I had to go on ward rounds with a consultant, and it was tricky to have the phone on me or the headphones, so I had to leave. But yeah, it was great. I have met the president of the Chinese Neurosurgical Society last year in Zurich at a bypass.
Oh, you met Ben before?
Yeah, I have met him. Actually, we had dinner at the conference dinner, and I asked for his card, and I still have his card at the back of my iPhone. So it was really nice to see him again.
Yeah, he actually translates into Chinese.
Yeah. I know. He's also president of the Chinese Neurosurgical Society. So
yeah, he goes out to make an effort. And you has ecstatic because, oh my God. Sorry about that technical glitch. Okay, you ready to start, Ada?
yeah.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have the pleasure of having Ada Kafai Golamati, medical student, 50-year from London, is going to be talking about virtual reality in neurosurgery. First, I want to, before Ada takes over, let me introduce Jason. Jason's going to be just appointed the host. Hi, Jason. Could you just explain your background a little bit?
Sure. Well, good morning, everyone. Thank you for having me on. And my name is Jason Evans. I'm from Toronto, Ontario, Canada. My background is in the field of healthcare. I came from a specialty pharmacy field, and for the past 5 years, I've been developing mixed reality technology. And yeah, I'm very excited for this presentation this morning from Ada.
Very good. Thanks, Jason. It's all yours, Ada.
Thank you. I'm going to share my screen so they can see my slides. Let me know if that.
Yeah, just say a little bit about your background and stuff. I guess if you.
Yeah, I hope they can see my screen now.
Yeah, perfect. Perfect.
Yeah. So good evening, everyone, or good morning. I'm not sure where you're at. Here in London is 1 p.m. and I am at home. So I'm giving this talk, which I have prepared for a neurosurgery audience, but I've tried to change it and make it more comprehensive for everybody so that I don't know what backgrounds you are from, but I hope it gives you just an overview of the application of virtual reality neurosurgery. My name is Aida. I'm a medical student at Imperial College. I did medical sciences before doing medicine with neuroscience stream. So I worked as a scientist briefly over the summer before joining medical school. And I have a passion for technologies, robotics, and all the new sort of tools we use to improve patient healthcare and outcome. The title of this talk is inspired by Michael Lawton, who is the president and CEO of Barrow Neurological Institute and probably one of the most famous living neurosurgeons. He defines a good neurosurgeon as someone who is virtuoso. And by virtuoso, he means someone who's got good hand skills and can handle tissue in a delicate way and has good surgical skills, but also somebody that knows where he is in the brain, knows the anatomy, knows what are the landmarks and what are the structures that it need to avoid intraoperatively in order to properly avoid a disaster, as he's a vascular neurosurgeon. Vascular structures are very delicate. So
excuse me, Ada, your screen is not advancing. Did you know that?
It's not. Yeah. No, this is still on the first slide.
Oh, okay. I'm sorry.
I'm sorry. The virtuoso title, which is inspired by Michael Lawton's definition of a good surgeon.
Okay, I'm sorry.
So, I hope this goes. Yeah. So I just made a little disclosure that my research was funded by the Hamlin Center for Robotic Surgery at Imperial College. So virtual reality is a way of expanding precision and giving the surgeon an opportunity to have a 3D image of the 2D imaging, for example, from a CT scan or an MRI scan, and gives him a better idea of where he is within the patient's brain or spine. So it was defined as, it was said that with virtual reality, we can plan out how we can approach a tumor and avoid the critical areas like the motor cortex or the sensory areas. Before, we didn't even have the ability to reconstruct it in 3 dimensions, and we'd have to do it in our minds. So once we study anatomy as doctors, you study it normally on books, or you do cadaveric dissections, or you have some simulated models. But then when you are with the patient, all you see is a really tiny hole within the brain. You have the scans on the monitor, and you have to kind of combine these two images in your head and understand where you're going, which structures are nearby. So virtual reality gives the surgeon the opportunity to maintain the focus on the surgical field while having this 3D image of the intracranial cavity without having to move his head or without having to do any mental effort at all. So it is a human-computer interface that simulates realistic environments while enabling participant interaction as a 3D digital world that accurately models actual environment. So this was the definition given by Lanier in 1987. And more than 20 years later, on the 17th of August 29, Dr. David Clark in Halifax performed the first brain tumor surgery, 24 hours removing a simulated tumor. So that was the first time virtual reality was actually employed in neurosurgery. And this is him, this guy here at the bottom is Jaron Lanier. This device, this robot, was introduced in the 1990s, the dextroscope, and it allows the user to interact with a virtual patient, and it's composed of a computer-generated 3D multimodal image obtained from a DCOM tomography data, such as CT scans, MRI angiographies, MRI venograms, functional MRI, or CT angiogram, PET scan, etc., etc. So any sort of image that is visualized normally in a 2D, so two-dimensional format can be recreated in a 3-dimensional format thanks to this device. And it has a combination, a multimodality combination of polyclonal meshes, which I'm not going to go into detail, but you can look it up if you want, because I don't really understand the theory behind it. But this was one of the first devices that allowed to sort of create a virtual reality platform for doctors. So we've said that it's a computer-generated reality. We said that it fuses multimodality 2D images to create a patient-specific models in a 3D format, and you have to obviously wear these Google head glasses, the HoloLenses, in order to be able to interact with the virtual reality platform. So virtual reality, augmented reality, and mixed reality have been used a bit interchangeably recently, but they mean slightly different things. So augmented reality is a projection of a computer-generated virtual reality into the real world. So you can actually see the virtual reality image into the space where you're at, into the physical world where you're at, still wearing the glasses. And the mixed reality is a projection of virtual objects into the real world, with the caveat that the objects are spatially aware and responsive, allowing the user to fully interact with projected 3D images. So if we want to put it as a sort of ascending, comprehensive platform, virtual reality is the most basic one. Then you've got augmented reality, and then you have mixed reality, where you really feel like you are there with the virtual reality object and you can interact with it. So the uses of virtual reality in neurosurgery and in surgery in general have been mostly for simulation and training. So augmented reality superimposes 3D virtual objects to real objects, and that allows to create an environment for doctors to train, because obviously it's quite difficult to get hands-on experience on real patient because of the risks involved in it, and because of the amount of operation you need to see, and sometimes you don't have time to go to the OR, sometimes the surgeon wouldn't want anybody, sometimes there are too many people who need to be trained. So this allows to create a training opportunity. It is used for preoperative and intraoperative planning, where you want to basically visualize the surgical field before you even approach it in real life, and you construct 3D images with real-time microscopic view to improve accuracy during surgery. So first you see where you're going and what you're doing, and then you kind of superimpose those images to your microscopic view to see whether they match and to see whether you are in the right place. It has also been used for patient engagement. So patients are often very anxious and very worried when you tell them you need to undergo brain surgery, understandably. So these virtual reality platforms have been used to show them what's actually happening within their head, and that has been proved to reassure them and give them a better understanding, and sort of allow them to be a bit less anxious about the procedures. So for preoperative and intraoperative planning in particular, before we used to calculate the parameters by relying only on previous experience and or imagination. So you were like, okay, this is where I think the middle cerebral artery is, or this is where normally the sylvian fissure is, and or I have this anatomical landmark, and this is the central sulcus. But we all know that people differ, anatomies are different, and so it's not a very reliable or safe method to just say, I'm going to base my next move in such a delicate organ based on my previous knowledge of anatomy. So with virtual reality, we are able to construct 3D patient-specific models for preoperative imaging used to map the anatomy. So we have the neuronavigation system, which allows you to basically, with a probe, understand where you are in the brain. You have the stereotactic location, which gives a point using geometric references. You have the minimally invasive, like, endoscope or whatever device you're using. You have the image guidance. And then you combine all of these and you give that 3D view of the surgical field, which allows you to be safer when you're operating. So this is a statement that I found in a paper by Tagayatayan et al., where it says that every time the surgeon wants to check his relative position on the patient's brain and the preoperative images, he or she has to switch views between the computer screen and the surgical field. This was before. And the preoperative image displayed on the computer screen is divided into 3 separate images. So the sagittal, the coronal, and the axial views. These are the imaging views. And the surgeon has to mentally merge these images in his or her brain to create a single 3-dimensional composite image. And they claim that the frequent switching of views during the surgery disrupts the surgeon workflow. So this has been a major challenge in the past of maintaining focus in surgery. and having to constantly look down, look up, look down, look right, look left doesn't really help to maintain the focus. And virtual reality has solved this problem, because you just look down in your surgical field and everything is there, 3D, colored, transparent, whichever way you want it. You can see right through it without having to move your head around. So as I said before, we used to use cadaveric dissections and textbooks for simulation and training. But now we have this fly-through brain to strip away layers of tissue to examine the anatomy, thanks to virtual reality. So this is diagram showing a setting of a virtual reality operating theater. So you have the HoloLenses where there is a camera and there is a sensor and there is the augmented reality display. This is all within the HoloLens. You have the lead surgeon who is wearing the HoloLenses here. And this is at the Royal London Hospital, which is a major trauma center in London. And this is actually displaying a very new way of doing surgery. So the surgeon in London is telling the surgeon in Mumbai how to do the operation thanks to this virtual reality platform. So the assistant surgeons, one in a hospital elsewhere in London and the other one from 500 miles away in Mumbai, are able to watch the operation in real time on their own headset. So whatever he is seeing, they are seeing, even if they're not physically there. And these surgeons appear as blue avatars in the operating theater and can provide vital assistance to the lead surgeon. So you see how they are displayed here. They're not really there, but virtually they are there. And information is being displayed in augmented reality in front of both three surgeons on these displays. So this allows an unimaginable level of collaboration with people that are not even in the same place. And actually, a very famous plastic surgeon called Nadime Hakakharam developed an app called Proximi, which allowed her to train surgeons in Palestine in the war zone on how to perform hand surgeries. And this platform, this app is based all on virtual reality. So this is the mechanism by which works. And this is how we can improve simulation and training of surgeons, even if when they are not there. So this is a little explanation of the virtual reality system structure. So you have the participants and you have the display and the sensor. So there is a multimodal interaction. So the participants have sensation and then so they feel something thanks to haptic feedback and they can act on it, and that represents their behavior. So you have the display where they can see things and you have the sensors which relay the haptic information. You have the virtual body, which is the reality created by the virtual reality platform, and you have the physical model, which is in front of them. And then you have various softwares, which sort of combine these information, and then they communicate the data to the computer hardware, which then processes them and gives feedback to the surgeon of what to do next. So this is a rather complex system, and I don't think there is any point in trying to understand it all unless you are very interested in the field. But the point is that you can see how there are multiple levels of checkpoints, let's call them, and interactions where information is relayed from the virtual world to the real world, and then it guides basically behavior of the operator. So behavior and sensory transducing subsystem converts natural behavior into digital information and digital information into physical consequences. The virtual toolkit subsystem coordinates and displays computational hardware, software, and software functions and resources and the world model. And computational subsystems such as the operating system and hardware customize the VR software to a particular machine architecture. So this is how it all works. But again, just know that it's a complex system and have a little insight into how it works. So the VR structure itself, there is the presence, which is the impression of being within the virtual environment. And then there is the participant inclusion, which is that boundary between the software model of the participant and the virtual environment. So when I mentioned haptic feedback, so haptic is basically the touch feedback that you get when you are touching something virtual, you still get a feedback in a VR setting. So haptic touch sensation is simulated by calculating the forces applied to a cut or a punctured tissue via force feedback loops. And a low update rate for soft tissue and a high update rate for hard tissue gives a relatively accurate feedback of what you're touching. But so far, the calculation cannot be made fast enough to update a display of 30 Hertz. So, and that's a limitation of the system. And some joysticks and gloves provide user with the sensation that they are, of what they're touching. If we go quickly back to the VR setting, just want to show you the gloves. Yeah, these are the sort of gloves that you wear and that here Jaron is wearing, and they allow you to get haptic feedback. Yeah, so this is a force feedback loop diagram. So you've got the motor commands, and then you've got the tactile information giving back to the human brain. So this is the surgeon hands, which is obviously wearing the gloves, even if here there is no gloves. The surgeon moves the hands. The motion is transmitted to the robot, in this case, the haptic interfacer, which then transmits it to the sensor, which position the information, and then they transmit the data to the machine. The force data is collected, and it goes to the actuator and brakes, which transmit it again to the haptic interfacer, which transmits it to the human skin, which transmits it to the brain, and then kind of guides motion. As you see, it's just a system where motor commands are guided by the sensory information that are received thanks to these gloves that the surgeon is wearing. So I am also involved in a relatively new field of research, which is new for me, actually, robotic surgery. And we are now looking at tool tissue interaction forces in surgery, and how can we determine whether there is a safe threshold, because a lot of surgical damage, especially in neurosurgery, ophthalmology, vascular surgery, is caused by applying too much pressure to the tissue. And that is because, especially when you are doing robotic surgery, the haptic feedback is not very accurate just yet. As we said, it can't go beyond 30 Hertz. So you might not get a feel of what kind of tissue you are touching, and then you apply too much force and you create a perforation or ischemia. So the surgeon's hand moves the end effector, which is the robotic arm, basically, causing the device to relay its position via sensors to a computer running a VR simulation. And on the left loop, forces at the end effector are detected and relayed to the user's brain, and force feedback occurs in real time to convey and engage the surgeon. So the haptic device's driver card plugs into a 500 millihertz computer equipped with a standard graphic card and regular color monitor. So you can obviously see all of this on a screen as well. So on the screen, you can also see a 3D model of the part of the body undergoing surgery, and this is a digitally mapped onto polygonal mesh. The virtual reality designers portray tissue as polygonal meshes that react like an array of masses connected by spring and dampers. This is a very complex physics concept for me, at least. And the color enhancement highlights bone and blood vessels and the structures you are more interested in. So you can obviously integrate colors to distinguish the structures. So now, strictly speaking about application of virtual reality in neurosurgery. So as we said, it allows the 3D representation of 2D images, and a surgical microscope overlays the planned 3D images directly into the surgeon's optical field. Hence, the surgeon doesn't need to move his head around. And for example, in preoperative planning, Cockrow et al. Described the sampling and testing of various clip sizes before surgery, aneurysm surgery, decreased mortality to 0% and morbidity within the single-digit percentiles for intracranial aneurysm repair, even if there was a previous subarachnoid hemorrhage. So aneurysms are tiny enlargement of the blood vessels. They're very dangerous because they can bleed at any time, and an intracranial bleed can be fatal if it's not treated promptly. And the clip is basically like a forceps, like literally a clip that is used to close the aneurysm on both ends, so that it's kind of the vascular supply to it's stopped and it doesn't bleed anymore. But the clip size is crucial because you need to consider how big the vessel is, where in the brain the vessel is, And being able to test the various clip size in a virtual reality setting can be really useful, because doing it intraoperatively can have disastrous consequences if you, again, as there is a really high risk of bleed. So that was for preoperative planning. It has also been used for surgical simulation, especially using liquid crystal display monitors. So the dextroscope, which was that robot that I showed you at the beginning, is the device that has been used for this purpose, and simulated views transferred directly to live patients allow intraoperative navigation for tumor removal, aneurysm clipping as discussed, AVM, arteriovenous malformation resection, cranial nerve decompression, and implants for epilepsy, maintaining constant focus on surgical field. So both surgical simulation and preoperative planning are very, very useful for the surgeon. For spinal surgery, we've had different tools such as Immersive Touch Simulator, Novington Falcon, Stealth 3D, Osso VR, and many others that have allowed the surgeons to train how to insert pedicle screw, how to perform vertebroplasty, posterior cervical laminectomy, foraminotomy. These are all procedures where you either cut a bit of the vertebral bone because it's compressing a nerve, or you insert some screws because there is a fracture. And these have been, for spinal surgery, they have been mostly used for training and evaluation of competency in surgical skills. Now, obviously, one important aspect of surgical training is being able to assess if the surgeon is actually good or not before you allow them to do any operation on their own. And doing it on real patient carries its own risk. So if you tell someone, well, I'm not sure how good you are at this, but let's try it on this patient and see what you can do. Well, if things go well, fine, great, excellent. If things go wrong, you potentially compromise someone's life just to assess someone else's skills. So it's not ethically very correct, obviously. And virtual reality allows to evaluate the competencies of surgeons as well. For cranial surgery, we've got, again, various systems, NeuroTouch, Immersive Touch, that have been used for training. NeuroPlanner is a stereotactic brain atlas that allows to map, plan, modify the procedure in real time with a mixed 2D and 3D reality simulation. And it has allowed to prepare for complication and identify optimal approach. And IBIS is an intraoperative brain imaging system. It's open source simulation platform. And it identifies the discrepancies between the preoperative imaging and intraoperative ultrasonography to update inaccuracies using augmented reality in real time. So in this picture, you can see that this is from IBIS. You have the vessels here. You can't see them, but you have superimposed the MRI, I believe, and then you have the vessels in yellow. And you can see the trajectory, you can see where it goes. So you know that you have to avoid it. Even if you can't, it's not physically there, you can see it thanks to the virtual reality. Same here, all these red vessels, they're not actually there, but you can see them. In vascular neurosurgery and for neurointerventional surgery, obviously we've mentioned aneurysm clipping, mechanical thrombectomy. This is a new, relatively new treatment for stroke. And the problem with mechanical thrombectomy is that not many people do it, so it's very difficult to train people for it. And virtual reality allows to train people. So it's a really useful tool for that. And it has improved positioning, incision location, enhanced outline of normal vasculature, according to the literature. For peripheral nerve surgery, we have a virtual reality assisted radiofrequency trigeminal rhizotomy. Provides 3D views of a foramen ovale and electrode needle tip for precise location of the trigeminal nerve, key surface landmark and radiographic cues. So trigeminal nerve is one of the nerves of your cranial nerve that runs through your face. It can cause excruciating pain in a condition called trigeminal neuralgia, and surgery of it is quite complicated. So virtual reality has assisted in that as well. And then things like carpal tunnel, which is a common surgery of the hand, of the wrist actually. And in this app touch surgery developed by Jean Neve, which is a plastic surgeon, again, based in London, he has simulated carpal tunnel surgery for training purposes. So the evidence in the literature is relatively, I would say, weak, because we don't have any randomized controlled trial. But there are proof of concept studies that prove that virtual reality improves understanding of anatomy in the preoperative planning, facilitates training without real patient risk. And also virtual reality and augmented reality improve intraoperative attention and focus in all surgical specialties, because the surgeon does not have to deviate their attention from the surgical field to a monitor, and therefore can improve 3D patient-specific anatomic evaluation and surgical ergonomics. Ergonomics is basically how comfortable the surgeon is in the operating setting, and how quickly he gets tired if he's not comfortable. Obviously, having to look down and up and down all the time while trying to reconstruct some 3D images in your head, you understand it's not the most comfortable thing in the world. So advantages of VR, we have obviously intelligent computer backup, minimizes medical mistakes. It's more effective minimal access surgical technique. So you make the hole and the incision smaller and smaller, decreasing infection, decreasing, post-operative complication, and also making sort of the aesthetic of it much better. And better training in anatomy and surgical skills reduce the needs for cadaveric training. There are lots of limitations, however. First of all, there is a very steep initial learning curve and continuous needs for training. So people can't just walk in a room and use a virtual reality setting. It's quite complicated. It can, it requires a lot of, sorry, not sure what I've done. It requires a lot of training. It adds time to the already long surgical training. So surgical training in the UK is approximately 8 years. I think in the US it's 5 years or 6 years. So imagine having to add a few months to this already long training to train them how to use a VR. It has shortcomings in realism of simulation. So obviously these are models, so they can't be 100% accurate. There are some time delays in simulator response to the user. So when we say real time, we say real time with a delay. So the delay can be anything between seconds to minutes, but it can be still dangerous to rely your next move on what the machine is telling you, because the machine may not be processing the information fast enough. These whole tools and softwares and devices are all very, very expensive. So obviously they're not available to all surgical centers. And the fact that the surgical centers do not acquire them makes the research in them less likely to happen, because the companies are like, well, if we're not going to sell these, we're not going to invest in doing any research in their usefulness. The ergonomic, again, although in the previous slide I said that improves the ergonomics, sometimes wearing these HoloLenses, the gloves, and like all the setting can be rather uncomfortable for some people, and some surgeons prefer having less things on them. It's a preference, or it's might about getting used to it. And then there is an ethical dilemma about, so this is an automated system that informs intraoperative decisions. So it's a machine that is telling you what to do next. So what if things go wrong? Whose fault is it? Is it the surgeon, the person who designed the machine? Or is it, who can actually take responsibility for things that went wrong? And then conclusions. So advances in the last 10 years have been huge thanks to the development of imaging. We have evidence that it improves quality of care and outcome, although it's not a very strong evidence, it's still an evidence. It reassures patients and helps in aiding consent for rather complex surgeries, because the patient has a better understanding of what you're actually going to do. It allows for better navigation and monitoring in robotic applications. There are lots of apps for training. So we've mentioned touch surgery, we've mentioned Proximy. So these all help in training surgeons for the future. And I think lots of people have suggested that creating a pan-surgical software and hardwares would decrease the cost for institutions. So if there is a software that you can use for, orthopedic surgery, neurosurgery, cardiothoracic, plastics, and everything, the institution would be more likely to buy them because it would be usable in multiple fields and it would decrease the cost of it. And that concept is called Simulation Alliance by Zhao et al. That suggested that, there should be pan-surgical softwares. And obviously, as in every, upcoming field in medicine, we need randomized controlled trials to see whether this is actually safe or useful at all in surgical training and outcomes. And this is just a video I took from YouTube. I would like you to watch it because it gives you just a taste of what is virtual reality surgery. It's 5 minutes. I'm going to play it. You can all watch it.
On Monday, June 5th, 2017, I felt the worst headache in my life, like an ice pick driving through my skull. A CAT scan revealed a bleed in the side of my head, the size of a softball. The only option to stop the bleed was to have a craniotomy to remove it. Being completely out of control is terrifying.
It's difficult to talk to patients about brain surgery because it's very abstract. We're combining delivering difficult news about a scary diagnosis with the additional fear of not knowing what to expect and not being able to understand what it is I'm explaining to them. When we show them the model, when they fly inside their own brain, they can see the structures, they can see the tumor, they can see the aneurysm.
This device creates an experience for the patient where nothing is unknown anymore.
Well, it's certainly daunting to think about somebody tinkering around inside your head. There's a whole bunch of anxiety that comes with that. Patients are looking for some hope. They're looking for a way to understand what's happening. What's made brain surgery historically pretty challenging is surgeons have to look at two-dimensional imaging and then in their mind's eye create a three-dimensional map of how they might approach the operation. We thought, you know what, we can intervene here and we can take MRI and CT scans and fuse them together in our software to create a virtual reconstruction and change the practice of medicine for the benefit of the family, the surgeon, and the institution. It is that person's anatomy VRalized. The Intel processor really allows our content to come alive.
We've worked with surgical theater, taking our latest desktop and notebook processor technologies so that we can very quickly render those 3D environments in the exam room and allow that patient to have a real-time immersive experience while their provider's in the room.
Hi there, good morning, good to see you again. What you're looking at now, this is a three-dimensional model of your brain. You see the tumor there in green?
Yes.
And you're getting something to see that most patients never get to see.
I was totally panic-stricken. I'm not a doctor, so I couldn't understand what they were trying to tell me because I had never physically seen a craniotomy before. It's so hard to wrap your head around what they're about to do. When I put on the goggles, my surgeon asked me if I was ready to fly. In the moments where they were telling me really terrifying things, I also felt a little bit of peace from the way that it was being presented. I was able to, in real time, see inside my brain. I was physically there with them, looking at exactly what they were trying to communicate.
Before surgical theater, preparing for surgery was literally me sitting over a cup of coffee, kind of thinking, okay, I'm gonna do this. And then I remember that the optic nerve is here, but those preparations were a kind of ad lib. Now, with 360-degree 3D reconstructions, we're able to be inside that environment, which is as close to brain surgery as we can actually get without being there in the operating room. The advantage that the virtual planning and rehearsal brings to our readiness for surgery is the ability to simulate multiple different approaches. In a real patient, we don't get to try that more than once. We only get one shot at it. In the virtual model, we can do 2 plans, 3 plans, 5 plans, and see which one is the best for the individual patient. Make the bone look a little more like bone, so it's not translucent at first. Now that I can see the frontal sinus, I'm planning it, yeah.
Let's bring in the microscope.
When we're in the operating room and we get to the time of surgery, because we've done the preoperative rehearsal, it kind of feels like deja vu, like, okay, I've been here before, I know where the important structures are gonna be.
Here we are, we're coming up to the back of the tumor right here. This would be a good place to do an overlay. Makes the tumor more translucent.
I was at the hospital in the ICU for 10 days, and I had 2 angiograms, 2 MRIs, 2 CAT scans, and a craniotomy. I had a risk of having epileptic seizures for the rest of my life, not knowing that I'd ever be able to drive a car again, that I would ever be able to run again. But I would say the biggest testament to how everything went was the fact that I'm sitting here today. It was nothing short of a miracle.
I think this technology is absolutely groundbreaking. I wouldn't use the word revolutionary. I would say it's evolutionary. I think virtual reality will change the face of healthcare. I think in some ways it already has. This is just an expertise that Intel possesses that has helped us advance in ways we never thought possible. People are demanding transparency. I think people deserve to be spoken to in a way that they can understand.
It made me more grateful for each and every moment that we have. We experience life in 3 dimensions. Why should our medical care be any different?
Yeah. So, and this is the people I would like to thank, are my mentors, and some doctors I work with at Queen Square National Hospital for Neurology and Neurosurgery and the ICL Center for Robotics. And this is my emails, my Twitter, my Instagram, and I'm happy to take any question you may have.
Okay, very good, excellent. Let me get you off the screen there, Aida.
Yeah.
Oh, you want to leave that up there? Or
Yeah, I can. I mean, up to you. You can leave it, or you can go back to normal screen.
Yeah, well, I'll do that in a second. But thank you very much. You know, you're working on one of the limitations, which is the learning curve. Most physicians, most neurosurgeons don't know what the heck it is, and I don't either. So we're working on that limitation with this technology. So Jason, I'd like to have you take over, and I'm sure you have a few questions, Jason. Why don't you start off and run the show? Go ahead, Jason.
Sure. So thank you, Aida, for the presentation. It was well informative and yeah, some very interesting discussion that you provided. So one of the questions I had was, oh, you're very welcome. You had mentioned several problems that you see VR technology being able to assist neurosurgery with. What are some of the top problems through your experience so far that you see?
So first of all, I think in neurosurgery, there is a lot of change that happens anatomically during the operation, especially for brain tumor surgery. So I saw a lot of glioblastoma resections in London. So glioblastoma are like solid tumors within the intracranial cavity, and they create what we call a midline shift. So they shift the structures of the brain, they push them around. They also sometimes obstruct the flow of the cerebrospinal fluid in the brain. So they create a lot of swelling, which again pushes structures around. So when you start removing the tumor and you start to suck out the tumor, these sort of spatial changes start to go back to normal. And that's why the anatomy then therefore changes as a result. And some structures which initially in the imaging were somewhere, now they start going back, shifting, you know, a couple of millimeters away. So the intraoperative change, it's quite significant, and you have to take that into account when you're relying your surgical resection based on previous imaging. There is, for example, in London at Queen Square, where I watched this surgery, they have an intraoperative MRI. So they scan the patient during the surgery, first of all, to see how much tumor they've removed, and also to have a better real-time view of the anatomy within the brain. So I think this is one of the challenges that we need to overcome. And of course, virtual reality has helped with it. But again, we've said that the real-time image created is not sometimes so accurate, is not so fast. And I think this is what you need to be careful with, because every single millimeter of the brain is functional. So either it's functional, so if you by accident damage it, the patient will have some cognitive impairment, such as, you know, being mute, being paralyzed or blind, or you may cause a very bad bleed, because these tiny vessels that run in the brain are extremely sensitive. And if you literally accidentally punch them, then this is it. There will be a bleed, which can have disastrous consequences. So it's very difficult, I think, to rely on images taken before the operation when you're removing something that might be, you know, 3-4 centimeters big and has created significant spatial rearrangement, which then start to go back to normal. This is one challenge, I mean, for my limited experiences. I see a question here.
Fantastic.
Yeah. So
you had also mentioned, you touched on robotic surgery with too much pressure being applied to the tissue. Robotic feedback is not very accurate yet, and you cannot go past 30 hertz. What's been your experience with the haptic feedback technology today?
So I have to say, I personally, being a medical student, I've never even stepped into the OR and like done any sort of operation myself. So everything I'm talking about is either based on the literature or some stuff surgeons have told me. I think haptic feedback, it's very useful for surgery. But what we've seen in our review, which is not published yet, we've submitted it, but it's not published yet, is that it is more accurate when it comes to hard tissues than when it comes to very soft tissues. So if you're talking about haptic feedback in orthopedic surgery, or even, you know, little ear bone surgery, or when it comes to bones or cartilages, the feedback is rather accurate, and you kind of have a bigger window in which you can apply forces and still not create any significant damage. But with neurosurgery, for example, most of the forces applied are below 0.0001 Newton. So the machine is not even able to pick up the forces you are applying. So it just gives you less than 0.001 Newton, which means that you never know if you're applying. So the risk are either you don't apply enough forces, so you don't complete the tasks. For example, coagulating a vessel, or, you know, perforating a tissue, you don't apply enough force and you don't complete the task. You apply too much force and you cause damage or bleeding. But we don't know how much force we need to apply. And there is no study in the literature that tells you this is the safe window for this type of tissue, or this is the safe window for this type of procedure. It would be something useful to identify in the future. But I don't think many surgeons rely on haptic feedback, especially for soft tissue surgery at the moment, because the forces are too small to be picked up by the machine. And you just really have to rely on, like, a lot of surgeons, for example, for brain tumor surgery, they told me they rely on the consistency. So they feel when they are, for example, sucking tumor out of the brain, they feel like the consistency of a healthy tissue is different than the tumor tissue. So tumor tissue is more sticky, it's more hard to extract, and therefore they get that kind of sensation from the instrument that it's sticky, it's hard, and they rely on that. There have been, you know, many, I think, ways of trying to identify healthy in tissue and tumor tissue. We have, like, now contrast enhancement, you know, there is the 5-ALA that is used to light up the tumor under the microscope. But still, I think what I've heard from the greatest surgeons who I have seen or talk is that a fool with a tool is still a fool. So you have to still have your background knowledge, and these tools can help you to improve your sense of security. But you can't just rely on these. I don't think so far we can't do that.
Excuse me, Jason, there's a question from a Nepal medical student. Now, Prath, do you want to try your camera? Her bandwidth is kind of low. Prath, are you there? Do you want to ask Aida directly, or you want me to read the question? Go ahead, Prath, try it, go ahead. Well, I'll ask her. Go ahead, Prath, try it.
So hi, Aida, I'm from Nepal, and
hi.
Yeah, I was a bit confused about when you said about, like, assessing the competencies of the trainees via the virtual reality.
Yeah.
Are there specific centers that are offering it right now? And is there any concrete research as to extrapolate those findings of the ability of the trainees to operate in a particular setting where only 2D images are used, as VR is not widespread as of now?
Yeah, so you mean, so your question is that if there is any way of comparing the assessment with the VR compared to the assessment with the normal ways?
Yeah.
Okay,
Like,
so
are there,
yeah, go on.
yeah, are there any centers that are offering like a VR-based training for
Yes,
students?
there is in Stanford. They are. I think in Stanford they are offering some virtual reality based training. So I have to say I am not aware of any center that is offering only VR based training. So training of surgery is obviously on cadavers to start with. So you start with cadaveric models. You have then 3D models, which are just sort of phantom models. So they're made of various materials that simulate the tissue. You have in-person teaching, so when you're actually do supervised surgery, and VR is just something to complement that training. It's not. I don't think there is anywhere where they train you based only on VR instead of VR and other things. However, I think so with Proximi, which is this software created by this plastic surgeon Nadina Hakakaram in London. So she, I think the claim is that I say the claim, but I'm sure it's true. They performed the first assisted hand surgery in Palestine, thanks to the team in London. So the team in London told the team in Palestine, who had never done that surgery before, how to do it, just through virtual reality. But more than training, that was assisted surgery, because they were seeing the same screen, they were seeing the same operating field, and they told them step by step what to do. But I don't think there is anywhere where they train based solely on VR. I think, I mean, if we compare the training based on VR and the training that we have now, the traditional training, probably the traditional training, it's still slightly stronger than VR alone, because you get a better sense of tissue, because you have, a better sense of dimension, because you also in VR you have all these colors and things that light up in real life, vessels, arteries, veins, the nerves, everything pretty much looks the same color. So you need to be able to distinguish them. But I think VR, it's safer and ethically more correct for patients. So if I were a patient undergoing brain surgery and someone tells me, well, this is the first time I'm doing this surgery and you are my, lab rat, I wouldn't be very happy. Now, nobody tells that to the patient. Obviously, you just tell them, we have a trainee surgeon doing your operation or an attending surgeon doing it. But I think it's ethically more correct to train on VR than on real patients. I'm not sure if
Thank you so much.
question, but I think in Stanford they are doing virtual reality training, as far as I know.
Beth, let me interject a question real quick. How much of online training can effectively be done in VR? I mean, obviously the hands-on is very important, but
yeah,
how much do you think can be done to prepare the person for hands-on?
So, I mean, in London, I have to say, for neurosurgery, in order to pass the board exams, neurosurgeons are expected to perform 1,200 operations on their own. So let's say that every surgical operation takes about 4 or 5 hours on average. Just doing a quick calculation, that would be 6,000 hours in the OR. Now, of those 6,000 hours, obviously they won't be doing the whole surgery, so probably they will do just 1/3 of it, so like 2,000 hours. So I think complementing surgical training with 1,000 hours of virtual reality would be feasible. It would just add really 1/6 of your existing training time, so it wouldn't prolong it massively. It may prolong it by 6-7 months, and it would be a fair adjunct. But for now, it's not happening. I don't think in the UK, definitely nobody is training surgeons to use the VR. If you want, it's sort of like a self-teaching thing, or you have to base your learning on what the company representative teach you when they present their devices, which is pretty good, but it's not a proper training.
You want to finish your question, Prat?
Yeah.
I'm sorry, Prat, I cut you off there. You had some more questions, right, Prat? Go ahead, unmute.
No,
Go ahead.
yeah, I think I'm good. So yeah, I'll look up on the Stanford training.
Okay.
Thank you.
Yeah.
Okay, very good.
I think there is a question by Yuri Kakimov, who asks if I have any experience with brain lab navigation. I don't have any personal experience, again, because I don't operate myself, I wouldn't say I have personal experience, but BrainLab is used extensively in London. It's used for neuronavigation especially. So you kind of superimpose the images from the MRI and functional MRIs on the screen, and then you use the probe to see where the lesion is in the brain. But yeah, it's widely used in neurosurgery, BrainLab. But I don't have any personal experience of any of them because I've never, sadly, done any operation.
Okay, very good. Any more questions from the panelists? It's open, and this is your chance.
Yes,
Pinky,
doctor, I have a
I
question.
see you're
Hello,
preparing it. Go
Aida.
ahead, Pinky. Go ahead.
So hello, Aida. I'm from Nepal. I'm a medical student here in Nepal. So first of all, I'd really like to thank you for this wonderful presentation. I mean, it was the first of its kind for me, and you actually gave a detailed explanation on the virtual reality. So there's a question that I'd like to ask. So how can you manage stuff with individual variations in using VR? I mean, there must be variations in patients.
Yeah.
Not every patient is same. So is there any way or any technology that helps in individual variation in VR?
Yeah. So basically, the way VR works is that it creates a 3D image from your MRI or CT scan. So the MRI and CT scan obviously take account of the anatomical variation of each patient. So each MRI, each CT scan it's unique in its own way. And the way VR virtual reality helps is that it creates a 3D image based solely on that specific scan. So it's not a pre-existing 3D model that they put in front of you and they say this is a normal brain with this is where the brain stem is, this is the basal ganglia here, this is the artery, and just learn this model and have it in your head and then try to apply. So the way now surgeon, I think they work, they use anatomical landmarks. So if they see, for example, the central sulcus, they say, well, this is where I expect the motor strip to be. This is where I think, the sensory function is. Or if they see the sylvian fissure, they say, well, this is where deep down there'll be the insula. So I'm not going to go there. But the virtual reality gives you a 3D model of that patient only while you are operating. So you wear these HoloLenses, you look down in your surgical field, and at the same time that you are seeing the opening, you see all the structures superimposed, so on top of your own view. So you actually see the patient 3D anatomy projected into your surgical field while you're operating. And in that way, it is very specific. I mean, it's that patient's MRI that has been translated into 3D. So you can't get it wrong. The problem is that how fast does this 3D image change when you operate? So the 3D image is based on the preoperative scan. As I said, during the operation, the anatomy changes because you are removing structures, you are retracting the brain lobe. So you put a retractor to open the surgical field. That already pushes things away. You are draining CSF fluid. There is bleeding. So the sort of volume of the brain can change. So all of these, they might have millimeters variations in space. And that millimeter variation, if you were to do if you were operating on the knee or on the femur, I would say, well, fine, it's a bit of bone here and there. So it wouldn't be a massive deal if you get a few millimeters of bone, you cut it off and you didn't need to. But for brain, it can have disastrous consequences if you, let's say, hit a cranial nerve. You thought that was, I don't know, a tiny vein. You just try to catheterize it, I don't know. And then it was a nerve, or you try to catheterize a vessel and it's like a major perforating artery of a major brain artery. So, and it's supplying, an important brain structure, and that will have ischemia. So it's difficult. I don't know how we can possibly compensate for this change of anatomy that happens intraoperatively, but perhaps more accurate real-time imaging, like faster real-time imaging could do.
Maybe Jason knows something.
Yeah.
What do you think, Jason?
Yeah, so that shift and drift is typical of what occurs with technology right now. And it's due to a limitation with hardware. And it's an acronym term SLAM, architecture, which is familiar within robotics and computer vision. So what you would be requiring is a combination of a spatial understanding is the term used for a device like the Microsoft HoloLens. And it's using IR camera sensors to continuously 3D map its physical environment that it observes. You can use object recognition using tools, middleware software such as Vuforia, which would be able to do image replacement, object detection, among other capabilities. So a combination of using robust SLAM architecture and hardware with the IR camera sensors. And I see a combination of machine learning occurring where it would be more or less mapping various scenarios that it could compute based on what the cameras are detecting to kind of compensate for that shift and drift. And it's happening already. It's been active research for a number of years. And they've been making improvements with how to minimize that shift and drift of holograms. And just give you an idea, a simple thought experiment is just imagine you have like a 3D object model that you can see sitting on your table, and you rotate your head quickly and you turn back to it. The camera sometimes will lose device tracking of its environment, and then the hologram gets replaced by a few millimeters. That's typical. So you need, there's a dependency on environmental factors as well that come into play. So proper lighting is one of them. IR cameras, they don't do well with objects that are black or glass. It doesn't, often you'll have holograms walking through windows if there's any glass in an environment. So yeah, there's a number of factors that have to be accounted for. And I think you look at the risk involved during a live surgery, there's perhaps lower risk use cases that could be applied with the technology at this point until the technology hardware is more capable for, especially for that SLAM, the SLAM algorithms.
You know, Ada, this is why I love Zoom. Is putting together people from two different areas, engineering and neurosurgery. And I think really, you know, that's really my job, is to get people from different areas together. And certainly, Jason, do any engineers go in the OR and watch brain surgery? Or Ada, do you know any VR people that actually go into the OR to kind of get a feel for it and what they need to do?
Yeah, I mean, we work with engineers all the time at Hamlin. It's a center run by engineers, but it's part of the Department of Surgery and Cancer. So it is pretty common for engineers to go to the OR here. But I think that we need more multidisciplinary collaboration, because I mean, at least me as a trainee doctor, I have little understanding of the engineering behind this, or like how imaging is even acquired. I don't think any of the doctors, or at least it would be maybe an insult to say so, but I think few doctors know how, for example, MRI images are acquired, or even how, for example, a robot haptic feedback loop works. So if we could do more multimodality teaching, and doctors could learn more about engineering, and engineers could learn more about what doctors need, would be a better perspective for the future. Because I think the engineers need the clinical perspective to understand what would make the surgery actually easier rather than fancier. And the doctors need to have a bit more understanding of how these technologies work to make.
Well, yeah, communication is the key. I mean, this is a communication platform. I think, things will get, it'll get better. It definitely will get better. Now, any more questions from the panel? Do you see any in the chat? I don't see any in the chat.
No.
I just had a question, Ada.
Go ahead.
Yeah, around integration, because that seems to be a big problem with this type of technology and bringing it into, the healthcare system in given geographies. Through your experience, you had mentioned you've seen this technology used in surgeries. How did you see that integration happening? Was it standalone software? Were they tapped into existing medical systems of that hospital? And also, did you recognize any methods used on how they were able to integrate that technology?
Yeah. So the only hospital where I actually seen it used is the Royal London Hospital, where I've seen the proper virtual reality, like a virtual reality aneurysm surgery being performed. They had a rep from a company that helped them to set up the system. So again, none of the scrub nurses knew how to do it. None of the surgeon knew how to do it. So the surgeon just literally wore the VR glasses and was being guided in what to do by the representative. And then once you start the surgery, then I think it's pretty self-explanatory. You just kind of have to follow the images and see how it goes. But it was a special operating room which was set up for this surgery specifically. There were reps, there were engineers, there were the doctors, and the doctors were heavily relying on instructions receiving, so they were not kind of feeling at ease on performing that on their own. And it went well, but I know that I wasn't there when this happened. I mean, I was there during the surgery, but I wasn't there when the preparation for the surgery happened. I know that they had multiple simulations before actually doing it in vivo. So it was a long preparation for it, and it was the only time. It's not something that happens every day. It also was quite a lengthy thing to get consent from the patient for such a thing. And I think it's still doesn't really run smoothly. It's not like performing VR surgery is something that happens every day, at least not in neurosurgery. It still has a long way to go before it becomes standard, I would say. But yeah, it was with the help of the reps that they could do it. I think there is the video of this is online on YouTube. It's from Brain Book, which is this charity that is sort of wants to demystify neurosurgery. I'm just going to pop it in the chat for everybody to see if they want to go and watch it. It's called Brain Book. They put this video of their VR surgery performed online, and you can see there are lots of people in the operating room, more than they usually are. And yeah, it looks like a show. It's quite nice.
Aida, could you put up your contact info and
course.
Right now, so people that may have missed it,
Okay.
and the
Absolutely.
websites, relevant websites?
I have my Imperial email. I have my Twitter for whoever is interested. I think we do. I would suggest that people, they just, there is a lot online, especially nowadays, thanks to Zoom and Microsoft Teams. There are lots of courses going on, lots of conferences. Just get involved if you're interested, because nobody will come and I'm speaking to the doctors, nobody will come and teach us about these things. And it is our own responsibility at this stage to kind of try and learn about the new technologies. In 10-15 year times, probably the face of medicine will have changed. Everything will be digital. We will be all working with robots. We will be all working with virtual reality. So it's time to learn now. And unfortunately, this is unlikely to be integrated in our training so far, because the training is already very long and nobody wants to add any more years of training, understandably. So we have to make our own effort to learn. And I think this is an excellent opportunity during this pandemic to attend as many courses online as possible.
Yes.
Follow Stanford, follow MIT, follow Johns Hopkins University does loads of robotic stuff, and get involved. And if you can, educate yourself about the topic, because nobody's going to do it for us, and we will be expected to know when we start practicing. And it will be difficult if we have absolutely no background.
I didn't realize it was required. Wow, that's.
I mean, I guess it will be. I'm pretty sure it will be, because we are fast moving towards a more digital world. And at least in the UK, we have the NHS-X, which is like a proper body of the national healthcare system created to make the NHS all digital. So I would expect things to become more and more tech-oriented.
Yeah, well, it's a great future, and you have a great future. Yeah. You're very focused. I'm sure you do fine in the OR.
Thank you for listening. Really a pleasure.
Yeah, thanks for the spending the time, and thanks, Jason, for coming by to add a little
Thank you
expertise.
so much, Jason.
And just hang out a little bit. There's a couple of people I want you to meet, which is another plus for these webcasts. So thanks a lot. Thanks a lot, Ada.
Thank you so much. I'm really grateful. I'm happy to receive emails, questions. Just feel free.
Yeah, can you we didn't see your contact stuff up there yet. It's not up there.
Yeah. Oh, it's not. I sent it to the panelists.
Oh, can you put it on the screen like you don't know, like a screen share?
Yeah.
That's a little easier, I think, for some people to, because some people on smartphones, it's hard to copy and paste.
Oops,
Okay, we'll just leave that up there, and I'm going to end the broadcast.
Thank you.
I'm going to stay here. Hold on, Ada. I want you to meet a couple of minutes.
I will hold on.
Yeah, Pinky, you there, Pinky? Yeah, let me.
Yes, doctor, I'm here.
Yeah, you met Ada briefly, right? And you asked a question.
Yeah.
You know, Ada, that's the way to
I
meet.
did.
That's the way to meet people. You ask questions. Okay, hold on. Yeah, let me get you up to share. I'm going to stop the screen share for a second. Yeah. Yeah, it's are you getting any training? Pinky, are you getting any training in Nepal? I mean, it's something that's probably just in the centers that have received training in 3D, right? Because not many places have it, right?
Yeah, right now in our country, there's no such
there's
facility for having trainees as such. So I think it's great to know things online, and knowledge about it is really important. But we don't have such things right here in Nepal.
But,
we don't have it either, Pinky. We don't have it either.
You know, how much of the training can people do online before they hit the lab? I mean, they got to hit the OR lab to learn this stuff. Can they take courses online?
To anybody who wants.
Yeah.
So I'm gonna suggest a few apps to download. I'm gonna put them in the. Actually, I may just put them on the chat for people who are interested. One is called Touch Surgery. These are all free. So you can download them on your mobile phones or your tablets. They tell you how to do step-by-step operations, the most simple operations. One is Touch Surgery. Thank you, Dr. Wagner, my very good mentor from Brazil. Thank you. He just wrote the message. And the other one is Proximi. So I would recommend that if you're interested in getting some surgical training. Yeah, it's an
Touch
app.
Surgery's been around for a while,
it's
right?
free. It tells you how to do. Yeah. It's been around for a while. Yes. Proximi is another one which is relatively new. And
Upsurgeon.
If you want to have
you seen Upsurgeon?
Pardon?
Upsurgeon.
Yes. Upsurgeon is developed by some surgeons in Italy.
From Italy,
Federico
right?
Nicolosi is actually the guy who developed it. Yeah, I know them. They are based at the Humanitas Institute. That's also.
Now they use virtual reality. They use virtual reality in that platform.
Yes,
they do.
They use, but they are only for neurosurgery. Upsurgeon is only for neurosurgery, while Proximi and Touch Surgery are for all surgical specialties.
Okay.
So they are more comprehensive.
Okay.
Yeah, they would. Any innovations in
and
the
those are free.
Aneurysm
So
surgery.
anyone.
So far, Dr. Wagner, for aneurysm surgery, they've tried to sort of try the clip sizes before clipping the aneurysm with a virtual reality setting, and that has improved outcome. But it hasn't. There is no other evidence in the literature about what sort of help it can do for aneurysm surgery. I'm sure there will be more in the future.
Marcus, come on the camera. Why are you being shy? Marcus, you're there. We did a conference with Marcus in Brazil.
Yeah.
Are you there? Marcus, are you there? Are you still there?
Dr. Wagner?
He's there. Come on, Marcus. Come on, wherever you are.
Hello, Aida. How are you? Great
talk. Hi, Dr. Wagner.
I cannot show any picture because I'm on the beach here.
Oh, okay.
Not in Miami, but.
Oh, okay. Oh, very good. Way we go. There you go.
I'm in João Pessoa
Oh,
City.
wow. Are you with
Aida
Targino?
knows you. But great talk, and we hope in near future AI and robotics can bring more than we have now and bring good results for our patients.
I'm sure they will. I'm sure they will.
Where are you at, Marcus?
I'm in João Pessoa City.
Oh, okay. Very
It's
good.
it's like Miami, baby.
Yeah, it's not very crowded, huh?
No, people are afraid.
Yeah.
We are in the second wave right now.
Yeah.
But
well, that's great.
I
I see you.
Really happy for the opportunity that you gave for Aida. He deserves that more than that.
Okay.
Thank you, Dr. Wagner.
Yeah. Anytime you want to, whatever your center wants, do they? A lot of research centers don't want their research to be known. Are you in that kind of a place, or can you pretty well talk?
No. We are not like that. We are very open about everything we do. I mean, I think an important part of research is public engagement. So if you don't really share your findings and you don't get feedback and you don't, just collaborate, it's pointless. So none of us, I think, thinks that.
Oh, okay.
Share.
Okay, anything that they want to share, that they want to, anything we can, if it impacts neurosurgery, we'd love to televise.
I'll tell my mentors. I have really good mentors here, and I'm sure they'll be happy to teach others. I mean, they know much more than I know. But I think it's important to just create some awareness about what's coming in the future.
Oh yeah,
for the
that's why I love Zoom. You meet people from other areas of life.
Yeah.
And it's up to us to exploit that. Like you said, it's up to us to go after it. On the internet, you can go after it.
Absolutely. And it's a great opportunity during the pandemic. Just sit at home and watch as many Zoom and webinars.
Yeah, now's the time. I mean, these kids are meeting top neurosurgeons.
And if any medical student from wherever you are wants to come to London for internships at the Hamlin Center, I can put you in touch with people. Just email me at the Hamlin Center for Robotic Surgery. They're very open. They'd love to have students from all over the world, and you can get good experience here with some of the top robotic surgery in the world. I mean, I trained under Lord Darcy. He's the first person to have performed keyhole surgery in the world, and he's a very big name in robotic surgery. And they always are taking students from abroad for internships, for observership, for anything you want to come. Just email me, and I can put you in touch with the people here.
That's very nice. Just making connections. Anybody else want to meet Aida? Anybody else in the panel? Now's your chance, man. We're off the air. Oh no, wait.